Moving to the next one. Good evening, everyone. I'm Dr. Akshata. I head the medical team for anti-infectives in Pfizer. And on behalf of the entire team, I welcome to this session today, MBL Under Siege, Optimizing Treatment in the Age of Superbugs. Today we have with us Dr. Garifalia Pulakau. May I request her to join us on stage, please? She is the Associate Professor at National and Kapodistrian University of Athens, Soteria General Hospital at Greece. She's a co-founder and has served as the Secretary and Vice Chair at ECMID. She's served in the Executive Committee of the Hellenic Society of Chemotherapy, which is the most active scientific society of Greece in ID. Her area of interest include infections in critically ill patients, viral infections, AMR, and newer antibiotics. She's also currently the co-chair of the development of AMS guidelines for the European Society of Intensive Care Medicine and has more than 225 PubMed Index publications and close to 14,000 citations for her publications. It's our privilege to welcome her to India, to Mumbai specifically. Thank you, Professor, for joining us. With her, I also invite the chairpersons for today's session, Dr. Balaji. I'm sure he needs no introduction. May I call you on stage, Dr. Balaji? Dr. Subramaniam Swaminathan to join us as the co-chair with him. And we have Dr. Monalisa Sahu, who's also going to share her case experience with managing difficult-to-treat MDR gram-negative infections. And to moderate the session, may I call upon Dr. Parikshit Prayag onto the stage as well. With that introduction, I hand it over to Professor Pulakau for her address for the next few minutes. Over to you.
Well, thank you so much for this kind introduction. I'm really thrilled to be here in India. It's my first time. I'm very happy for the invitation. I thank the organizers and Pfizer for this kind invitation. So I'm an infectious diseases specialist. So I'm very, very happy to be in an ID symposium. These are my disclosures. And probably all of you in the audience are quite aware of the classification of beta-lactamases, the Ambler classification. And you can see that the main beta-lactamases are deactivating beta-lactam products, but the most problematic are those marked with red color, the class B, the so-called metallo-beta-lactamases, from the class A, the KPCs, and from the class D, the oxa-like variants. The problem today is mostly the metallo-beta-lactamases, and here in India, you're all aware of the New Delhi beta-lactamase. Probably the MBL producing Enterobacterales are one of the most important public health concerns. And I can see your country in deep blue, some other countries in deep blue. Mine is in light blue, but I'm afraid that in the next year we will follow you. That's why I am here. MBLs are of particular concern because they are spreading rapidly. We have new variants isolated at a rapid pace. They are transferable. Their encoding genes are transferable. They are ubiquitous in the nosocomial environment, and in some areas, like yours predominantly, they are also very common in the environmental setting. They can inactivate a wide range of beta-lactams, and they pose significant therapeutic problems as well as high risk for mortality. Also, the Asia-Pacific area has demonstrated the higher increase in these types of enzymes according to the surveillance programs. One of these surveillance programs, the Atlas one, is showing the trend of metallo-beta-lactamases in your area. As perhaps you are aware of, Enterobacterales have a rather stable proportion of OXA48 and NDM, but OXA48 is slightly on the rise. More significantly on the rise is among Klebsiella strains, and what is particular in your community is that among carbapenem-resistant E. coli, the predominant gene is, the predominant mechanism is that of NDM, and very, very small proportions of OXA48. You will see our epidemiologic situation from 2018 through 2024. As you can see in the far left of this slide, KPC was the predominant mechanism of resistance among carbapenem-resistant Klebsiella pneumoniae. We don't have a significant problem with E. coli. We have Klebsiella. So during these years, you can see that KPC is decreasing, whereas MBLs are on the rise. And in the last surveillance, the INCREASE study, which is a Pfizer-sponsored surveillance study in ICUs, you can see that their percentages are almost equal. And when we're talking about mechanisms, you can see that NDM is the predominant. Second in the rank is the combination of KPC plus VIM and OXA48 in very, very lower percentages. And what is even more interesting, in my opinion, are the antibiotic susceptibilities of those isolates. As you can see, in the carbapenem-resistant Klebsiella pneumonia strains that were collected, you can see that Astreonam avibactam shows a susceptibility of 94.5%, whereas the second better antibiotic is cefepime zidebactam. And the other available antibiotics are almost in the same range: colistin, tigecycline, even cefiderocol, which is not launched yet in our community, are in a susceptibility range of 50–55%. And if someone focused on Klebsiella with double mechanism of resistance, you can see that ATM-AVI is probably the best antibiotic to consider against these strains. Stenotrophomonas maltophilia is another important problem in my country and in other areas, perhaps to a lesser extent in yours. It is a bacterium with inherent resistance with many mechanisms, and it poses significant therapeutic problems, particularly in immunocompromised and ICU population. So you all know that we have an urgent need and challenges in the management of MBL-producing bacteria. First of all, we have a global spread, then we have diagnostic limitations, we have significant therapeutic unmet needs, and we have, for all these reasons, a complexity in the treatment. And when we're talking about complexity in treatment, you can see our available so far treatment options. First of all, we have aminoglycosides. Aminoglycosides, and particularly plasmomycin, which is not available in my country or in Europe, aminoglycosides have still the nephrotoxicity problem, have also a high rate of resistance when the strain is NDM producer, and even plasmomycin, the newest one, is inactive against strains that harbor the 16S rRNA methyltransferase. Cefiderocol is a new promising agent, but in the previous slides I have shown some disappointing views from our epidemiology. However, in other areas also of the world, heteroresistance has been reported, resistance among NDM producers, and also there are some conflicting outcomes from the clinical trials, and also there is a significant problem with the in vitro testing. Colistin is a very good partner, but with significant caveats: high nephrotoxicity, resistance issues, heteroresistance, poor lung penetration, and however, we still use it. Tigecycline is still our companion, although it was doted in the FDA with a lot of warnings. We know the PK/PD drawbacks, low concentration in the blood, in the plasma, no efficacy against the UTIs, and we know that it is a last resort therapy. Eravacycline is not available in my country. However, again, it is in the category of tigecycline and tetracyclines. We cannot use it for BSIs and UTIs. And against MBLs, there are limited data. And fosfomycin, finally, is a good companion in our epidemiology. However, it has a high resistance profile if it is used as monotherapy. However, we use it, and I would say that we use it with some success in combination treatments. Perhaps you will ask me, you have ceftazidime avibactam, and we can give it together with aztreonam. Why go to a new approach and not use what we have in hand and we use in the last 5 years or so? The co-administration approach is not indicated, is not advised anymore, for several reasons, which I'm going to explain in the next slides. First of all, and most important, it is not PK/PD optimized. Second, it is administered as separate compounds, and this may cause a lot of mistakes, a lot of misunderstandings between the physicians and the nursing staff. We don't have approved the means to test reliably the in vitro susceptibility. And finally, we don't have clinical trials. The data that are based for the use of this combination, the co-administration approach, stem back to observational studies, and they do not lack they lack randomization. So, having said that, how to address the challenges with MBL producers? First of all, we must identify the correct patient, the patient at risk. And these are the risk factors that are identified by our national guidelines. In every setting, there might be different characteristics. In our settings, previous ICU admission, previous infection or colonization with a KPC-producing CRE, hospitalization in the same ward with other patients carrying these microbes, plus severity of the disease, immunocompromising condition, and severity of the current infection, let's say sepsis or septic shock. The committee argues for the use of rapid methods such as FILMARRAY or CARBA-5, but those two modalities are not available in every Greek hospital, and I imagine the same applies to your epidemiology as well. So rapid molecular diagnostic tests are a very modern approach. They can be as easy as a lateral flow test that gives results in a few minutes, or more sophisticated like next generation sequencing. They still need some time, some difficulty to deliver it to the laboratory, particularly in areas where the laboratory is not 24/7. There is some time that is needed for the analysis, and an important issue is to report back the results to the persons, to the prescribers. I will give you some information about an important tool that we have in our hands. Most of the ICUs in Greece are using surveillance of cultures, colonization surveillance. This is a tool that we have in our hands since early 2000s, and as you can see in this study, we analyzed retrospectively VAP and BSI episodes according to their previous colonization and adequacy of empirical treatment. As you can see, if we perform both colonization in gut and in respiratory secretions, we have a very good concordance of the strain that produces the infection, and we have good adequacy of treatment. When we use only one of these sites, there is better concordance with VAP and respiratory secretions and with BSIs and gut colonization. Of course, this modality was done with impregnated with meropenem plates and not with a modern molecular method. However, as I told you, we don't have universally molecular methods in our hospitals. We try to work in collaboration with the ICU in weekly or bi-weekly rounds. We have to evaluate the surveillance cultures. Sometimes we don't have optimal frequency. The optimal frequency is 2 times per week. And in these discussions, we consider previous culture data. We consider the non-clinically significant bacterial counts because they represent colonization. And we consider very carefully when the bacterial species are changing in subsequent cultures. This may herald a new infection. We try to early adapt or de-escalate the treatment. And finally, we face important problems because we don't have at hand the new antibiotics. And particularly, we have cefiderocol as an early access program, Astreonam avibactam in an early access program, and we don't have at all durlobactam and sulbactam. So are there any solutions? Yes. Astreonam avibactam is a big solution in this problem with MBL producers, and you can see the in vitro data at the break point of sensitivity less or equal to 4 milligram per liter. You can see that a great diverse set of Enterobacterales shows 99% to 200% susceptibility. And these are data from your epidemiology, the in vitro activity of Astreonam avibactam, and you can see that Astreonam avibactam in MBL positive Klebsiella is 100%, but in carbapenem-resistant E. coli is around 93%, and your data, as you're all aware about this, are connected to PBP substitutions in E. coli strains. So, Astreonam avibactam also has demonstrated activity, in vitro activity against Stenotrophomonas maltophilia. And it has, the addition of avibactam lowers the MIC and fully restores the Astreonam susceptibility. So we may consider it as an additional treatment against Stenotrophomonas maltophilia. You can see that Astreonam avibactam has a full clinical development program, which starts from a preclinical phase and has advanced to a clinical phase. The clinical phase has now terminated phase 1, phase 2A, and phase 3. 2 phase 3 studies. I will present you later the results of the phase 3 studies. What is new with the fixed combination is that the components are in a fixed ratio, 3 parts of Astreonam, 1 part of avibactam. The infusion is done over 3 hours and every 6 hours, and there is a loading dose. These are important PKPD modifications, and these derive from the data, from the PKPD data that we have from the phase 1 and phase 2 studies. The whole thing is to have optimized PKPDs in order to have the optimal probability of target attainment. This is very important when you have resistant pathogens and critically ill patients. So the data have shown, the PKPD data have shown that a loading dose plus the 3-hour maintenance infusions, the fixed ratio that I explained to you, every 6 hours optimizes this probability target attainment, and particularly the loading dose allows to have an optimized exposure after the very first dosing interval. Aztreonam avibactam got EMA approval on April 22, 2024, and in India on March 5, 2025. The therapeutic indications are the same: complicated intra-abdominal infections, hospital-acquired pneumonia and ventilator-associated pneumonia, complicated urinary tract infections including pyelonephritis, and the Balader treatment of infections due to aerobic gram-negative organisms in adult patients with limited treatment options. So, as we said, Aztreonam avibactam provides an optimized and consistent dosing across indication, and you can see that the loading dose is 2.67 grams. The maintenance dose is 1.5 plus 0.5, total 2 grams of the drug. And you can see that the duration can differ according to the focus of the infection. And in infections due to difficult to treat bacteria, the treating physician can go beyond for 14 days. It is important to train the personnel about the necessity of the loading dose and about the necessity of giving 3-hour infusion in both the loading dose and the maintenance doses over the course of treatment. The recommended doses in the SPC are very clearly indicated, and you can see that when the creatinine clearance falls below 50, there is a modification in both the loading dose, the maintenance dose, and the dosing intervals. The infusion time remains the same across all renal function categories. However, today there is an uncertainty regarding dose adjustment in patients that undergo renal replacement therapy other than hemodialysis. In these cases, the patient needs a higher dose than patients on hemodialysis. The revisit was one of the two previously mentioned phase 3 studies. The objective was to randomize 2-to-1 patients with complicated intra-abdominal infections and nosocomial pneumonia on either meropenem colistin or the combination Aztreonam avibactam. And clinical cure was the primary endpoint, whereas 28-day mortality, safety, and other endpoints are serving as secondary endpoints. For the primary endpoint, you can see that Aztreonam avibactam was effective in treating adult patients with those two infections by MDR gram-negative bacteria. The overall clinical cure rates were similar between the two treatment groups, and the 28-day all-cause mortality was low and similar between treatment groups. However, in the microbiologically evaluable analysis, the clinical cure for MBL positive patient was 50% in the Aztreonam arm, whereas it was 0% in the comparator arm of meropenem colistin. And you will see later that this this fact is reproduced in the small, but not least, second trial that I will show you right now. The second trial, phase 3, was the ASSEMBLE trial that was prematurely terminated due to low recruitment of patients. This study has recruited in total 15 patients, 12 in the ATM-AVI arm and 3 in the best available treatment, which included combinations of colistin. You can see that the MBLs that were identified in this small population were in their majority NDM. And as I told you in the results, 42% of patients receiving Aztreonam avibactam with without metronidazole were cured, compared to none, 0%, among those who received the best available therapy. So small numbers of patients, but the results are showing towards the same direction. The EMA have stated that there are some limitations of clinical data for the combination ATM-AVI, and the limitation as far as the treatment of infections are concerned has to do that data are derived from Aztreonam alone, data are derived from PK/PD studies and sub-studies of the trials, and when the anaerobic gram-negative organisms are concerned, also we have data limited to the first study that included 422 patients, the first phase 3 study, and also from the PK/PDs. So in order to stress your attention once more in the PK/PDs, I will show you this study that was published a few weeks ago. And this study verifies why this is the selected dose for the combination. The approved regimen provides more than 90% joint PTA at steady state across all renal function categories, other than end-stage renal disease and acute renal and augmented renal clearance, but this only for complicated UTIs. And it is important to know that for all renal categories, we have a consistent and effective dose. What gaps are filled? We have a fixed combination that allows us to avoid administration gaps and mistakes, and we have a 3-hour infusion that is the same independent of the renal function. In the microbiological spectrum, we cover Enterobacterales at the EUCAST breakpoint of 4, MBLs, KPC, OXA, and even GES and IMI enzymes. It also offers activity against Stenotrophomonas. However, there is a gap. It has reduced activity against carbapenem-resistant Pseudomonas aeruginosa as compared to ceftazidime avibactam. And I would like to go quickly to the cases. There is a male, 46-year-old, with history, diabetes, arterial hypertension, dyslipidemia, alcoholism, schizophrenia. He is transferred to the ER due to fever up to 40 degrees Celsius, arterial level of consciousness, and type 1 respiratory failure. He has increased levels of YBC count and some electrolyte disturbances. No specific findings in the imaging, and the patient, due to his condition, is intubated and transferred in the ICU. Upon suspicion of encephalitis or meningitis, he started on ceftriaxone, ampicillin, vancomycin, and aciclovir according to our guidelines. In the lumbar puncture, there were no findings, so we stopped aciclovir and ampicillin. And in the first culture of bronchial secretions, we have candida. And 4 days post-admission, he has a blood culture positive for Klebsiella pneumoniae and Pseudomonas aeruginosa. So based on these results, a new antibiotic regimen is initiated, including meropenem, colistin, fosfomycin, and caspofungin. As you can see, it is based on the susceptibilities that we have in the antibiogram, and it's quite striking for the Greek epidemiology to have a patient for so small interval in the hospital that harbors a resistant pathogen. The patient initially improved, but in the next days he deteriorates with a new episode of fever, and then the rectal swabs show Klebsiella KPC, Vim positive, and DM positive. And the new blood culture shows Klebsiella plus Pseudomonas aeruginosa. The antibiogram of those two strains is very disappointing. You can see that there is susceptibility to colistin in only one of the two strains. And fortunately, the MIC for Astreonam avibactam is good for both strains. So at this time, we stop meropenem caspofungin. We retain in the combination colistin and fosfomycin, and we add Astreonam avibactam in the antibiotic regimen. However, we are already on the 4th day from positive blood cultures because Astreonam avibactam has to be ordered and is not readily available. During the next day, hopefully this patient is doing well, is improving clinically, and finally he is discharged from the ICU to a rehabilitation center. A second case starts quite similarly. A male, 76-year-old, COPD, coronary artery disease, urinary bladder carcinoma under treatment, and other comorbidities. It is a common patient in our hospital. He is transferred again with fever and productive cough, with normal WBC count, again electrolyte disturbances, and in the chest CT scan, we can see bilateral pulmonary infiltration. Negative for SARS-CoV-2, negative for urine antigens, and he is again hospitalized with ceftriaxone azithromycin according to the CAP guidelines, and is escalated to piperacillin tazobactam plus azithromycin because he deteriorates and has altered mental status. We add the cocktail for encephalitis, and after the lumbar puncture, we retract it. On the 5th day in the ICU, he has already Stenotrophomonas maltophilia. We add levofloxacin according to the antibiogram, and on the 6th day, again, we have a high spike of fever, and then we have Pseudomonas aeruginosa. According to our epidemiology, we add colistin, and the patient is stable for some days. On the 11th day, we have new fever and increased needs for vasoconstrictors. In the bronchial secretions, now we have Klebsiella pneumonia, KPC, and Vim positive. In that case, we discontinue meropenem and we start the combination ceftazidime avibactam together with colistin and Astreonam. However, our goal is to have Astreonam avibactam. And here is the antibiogram. It is a pan-resistant strain. It is colistin sensitive, but the patient does not respond to colistin. So we consider it like a pan-resistant strain. And given the susceptibility, in Astreonam avibactam, we order this compound. 2 days later, we have Astreonam avibactam, and we stop all the other antibiotics and retain only colistin in nebulized form. After that, the patient is good and is extubated. Should I go to the final case?
In the interest of time, I'll hand it over to...
Do I have time for the third case?
We only have 10 minutes to go. Maybe in the interest of time, I'll skip this one.
Okay. What do you want? They're already tired. I think we could stop. So I will skip the third case and I will go to the conclusions. Aztreonam provides treatment with favorable effectiveness profile against MDR infections. It is addressing the global AMR crisis. It is an optimized PK/PD treatment option and has a favorable safety profile. I believe it is part of the solution that we have worldwide. And I think that in both countries, with many disparities in terms of population, but with many similarities in terms of epidemiology, we stay united against antimicrobial resistance. Thank you very much.
Thank you, Professor. With that, I call upon the case presenter for the India presentation, Dr. Monalisa, who is the consultant ID at Yashoda Hospitals, Hyderabad. Over to you, ma'am. I hope the slides are... Yeah. The slides are not reflecting. Yeah, thank you.
Thank you for the opportunity. I shall be presenting our experience with the drug, with this new drug. So he was a 32-year-old male who was a software engineer, and he presented to us with a cough and a previous history of occasional massive hemoptysis since 3 years and shortness of breath, grade 3. And he was diagnosed to be a case of chronic thromboembolic pulmonary hypertension, a rare condition. And for that, he underwent bilateral pulmonary thromboendarterectomy at our hospital on the 29th of July. Since post-op day 7, he started having fever with chills, and there was an increase in the cough with sputum production, although there was no hemoptysis. The blood culture and the sputum culture at this stage were showing no growth, and he was, during this period of 7 days, he was administered antibiotics like the cefepime, minocycline, the meropenem, but the cough and the fever persisted. On the post-op day 14, he was febrile, although hemodynamically stable, and the respiratory parameters were the respiratory rate of 20 per minute, and the SpO2 was 95% at room air. Bilateral air entry was adequate. The lab investigation showed a high TLC count of 18,000 with a neutrophilic predominance of 76%, and the CRP was almost 30 times, like 14.8 with the normal at our lab being 0.5. The serum creatinine was normal. Rest of the findings were not very supportive. At this stage, a CT test was done which showed the post-anatomy status with patchy opacities in the right lower zone and minimal bilateral pleural effusion and a pericardial effusion. The repeat blood cultures were sent and the sputum cultures were also sent. At this stage, the blood culture showed a Klebsiella, growth of Klebsiella pneumoniae, which was XDR1, resistant to almost all the drugs, and even the sputum culture grew the Klebsiella pneumoniae, which had a similar susceptibility pattern. The expert carbar was done for the patient, which showed the presence of the enzymes BLA-NDM and the OXA48. So at this stage, what do we do for the management of the patient? Do we ask for some additional tests? Yes, we can ask for the synergy test for the newer drugs. Do we start some drug combinations? Prior to having this drug, we have been giving the ceftazidime, avibactam with the Aztreonam combination. Start polymyxin B. If the synergy is negative, we would go ahead with the polymyxin B. But are there any newer treatment options? Yes, we do have one. So the synergy test for this patient showed a positive synergy test, and we went ahead administering the drug injection Aztreonam avibactam. It was administered as a loading dose of 2 gram over 0.6 of avibactam over 3 hours, followed by a maintenance dose of 1.5 over 0.5 infusion over 3 hours every 6th hourly. And the patient symptomatically improved. He was afebrile by day 3. The cough had significantly decreased and the lab parameters had improved. The blood cultures, although it's not a routine practice to send the repeat blood cultures, but in this case, since we were giving a newer drug, we sent the repeat blood cultures on day 9, and it showed there was no growth at 5 days. As the patient had a hospital-acquired pneumonia with the bacteremia, we went ahead giving 14 days therapy to the patient with Astronam and Avibactam. The patient was discharged on day 14 of therapy, and a couple of days back he presented to the OPD and was doing well at the day 15 post-discharge. So with this new drug, we have got several advantages. It has got activity against the MBL producing organisms, which are the major carbapenem resisting mechanisms in our country. It has better activity against the CRE and even the colistin resistant Enterobacteriaceae. There have been proven efficacy, as madam has already shown in a study talk, and the tolerability profile is also acceptable, and there are several cumbersome things that are there with the administration of ceftazidime avibactam with Astronam that we have been facing over the last few years. They are not there when we have the combination drug. So this is our case presentation. Thank you. I hand it over to Parikshit sir for the further discussion.
Thank you, Mona Lisa. So we just have 5 minutes left for the panel discussion. So I think I'll ask one question each to Balaji sir and Subra sir. Dr. Balaji, I'll start with you. Yes. So E. coli synergy testing, it has been a problem. And so what is your own experience, and what are the sort of pitfalls of synergy testing that we'll do away with once we have access to the Astronam avibactam E strips?
So you have answered that question. So the headache of doing synergy test is come to nil. Means in another 2 weeks' time, I don't think that anybody needs to do a synergy test in our lab. Because already FDA and EMA, UCAST and CLSI have given the breakpoints. All you need to do is disc diffusion or broth microdilution, and probably E-test also must be available. So absolutely there is no need to do any synergy testing.
Right. So what are your current failure rates though for E. coli?
Current?
Failure rates for E. coli.
E. coli, mechanistically, if I have to speak, definitely PB3 insertion won't affect the treatment prospect, because it is indicated for NDM. Almost 99% of the NDM in India has got insertion, PB3 insertion. So easily it can overcome. Only the problem will arise when AMP-C adds on. So wherever AMP-C is there, that's the reason why increased amount of avibactam is added for stabilizing the AMP-C. Sure.
Subra sir, we've been using the combination of ceftazidime, avibactam, Astronam for a few years now. What value addition do you see with Astronam, avibactam? I mean, we've been talking about the PK/PD. The threshold concentration has been more optimized. So how do you see that adding to practice, and do you see that as a challenge, getting the right kind of dosing strategies in India with the cost constraints for Astronam avibactam?
I think there are a couple of points which are worth looking at. The first thing is a practical point. When you have to use ceftazidime avibactam and Astronam separately, each one is 100 ml. So that's 200 ml at one go, and Q8H will be 600 ml of fluid. And in an ICU patient where sometimes fluid is a luxury, 600 ml is enough to get the nephrologist after you for your blood. And if you can get away with 400 ml per day as compared to 600, that clearly is an advantage in volume sensitive people. The second thing is, unfortunately, like Balaji pointed out, the dosing of Astronam and avibactam is not optimized in the MBL kind of a scenario. And for E. coli and Klebsiella, the escape mechanism seems a little different. And that is optimized when you use this kind of a combination. We cannot use Q6H of ceftaz-AV simply because the ceftazidime is going to start causing problems at that kind of dosing. And 2 grams of Astronam Q6 is going to be really toxic. So for a lot of reasons, I think trying to force this into a Q6 kind of a mechanism is going to be very difficult, because volume will also go up to now 800 ml. And therefore, I think this is going to be not a viable option for us to fit. Yes, we have used it for so long. Yeah, but we also used colistin for a long time, and we now know it's a pretty horrible drug. When you are down on your luck, you will take anything that comes your way. But when you have a better option, something which is easier to use and probably not hammering a round peg, square peg into a round hole kind of a thing, why not do that? So I think for a lot of reasons, using Astronam avibactam makes a lot of sense. And in my own thinking, I would see ceftazidime being replaced as a front-end drug with Astronam avibactam, and ceftazidime moving to the back end.
Thank you. So I think these are two important messages. If you come to the in vitro part of it, I mean, we'll be doing away with this synergy testing. We've seen how complex synergy testing is, and coming to the PK/PD aspects, I mean, the probability of joint target attainment is much better optimized in a combination like Astronam and avibactam. Unfortunately, we don't have time for more questions, but if there are any questions from the audience, we'll be happy to take a couple of questions.
Good evening, doctors. First off, thank you, Dr. Pulaku, for such an informative talk. My question is about the revisit phase 3 trial. So the trial, I can see, was undertaken for 2 indications, namely intra-abdominal and HAP-VAP. But I've read that the US FDA has only given approval for intra-abdominal infections. So could you tell us more about what could be the reason for that?
Thank you for your comments. As a matter of fact, there was a second study that targeted more infections, but there was not big recruitment. As you can see, the indications that were given by the authorities have also the mention that we have inadequate data based on clinical trials. This is very clear in the approval of the product. And according to the data that come from the clinical trials and the PK/PD information that we have from the phase 1 and phase 2 studies, we decide to go for the approval of this agent because there is a huge lack of therapeutic options in this field. I acknowledge that the big trial with 422 patients has only 2 sites of infection.
All right, thank you.
I think we'll wind up in the interest of time. So thank you everyone for attending this session. Thank you.